Good evening, everybody. And I'm Dr. Agambora, chest physician at Mumbai, and your host for today evening's program. We're going to be talking about hypercoagulability with COVID-19. COVID taught us many new things for the first time ever. I witnessed for the first time such a big pandemic as a doctor. Trust me, as a helpless doctor. First time ever, we lost 2,100 doctors in this battle against COVID in just 24 months. And that is, if you calculate mota mota, we lost almost 2 doctor lives every day in this war. We lost about 5 lakhs direct deaths due to COVID. And most of us believe that almost similar number, another 5 lakhs, would have died because of COVID-related complication, where hypercoagulability is number one. You have respiratory failures, pneumothoraxes, pneumomediastinums, and sepsis, multi-organ failures are the related deaths, somewhere around 5 lakhs, which would mean every minute we've lost one patient in our country for last 2 years. First time ever, I saw a virus which has got capacity to stimulate your immunity in such a way that patients would go into cytokine storms. Who would understand it better than we chest physicians that this virus acted more as allergen than as virus and gave you worst possible immune reactions, leading to death in many. First time ever I saw that almost every patient experiencing this hypercoagulable state. And I've seen it for the first time in my medical career. So many new and repurposed therapies for COVID. And also first time ever I saw vaccine development so fast and vaccination, mass vaccination of the entire country. This wonderful program happening in no time. COVID virus kept on changing its structure and we kept on getting new variants. Alpha, beta, delta, and now this Omicron. With change in its structure, it changes the disease pattern, its infectivity, and it may have a huge impact on available therapeutics. Your medicines may not work, your vaccines may not work, your diagnostic may fail. I remember soon after I started seeing COVID in Mumbai, we realized that COVID leads to hypercoagulability, and this needs to be addressed. My first ever patient was actually a patient who presented with stroke. And in the same first month, somewhere in March, when I started seeing COVID, I lost 2 young patients, and I believe now they were suspected embolisms. We soon realized there was urgent need to anticoagulate these patients, and all of us started using low molecular weight heparin in hospitalized patients, and then NOACs when you discharge them, or NOACs when you're managing them at home. I'm currently a secretary of Academy of Advanced Medical Education. Under that academy, we took a survey of more than 800 physicians across the country, and we analyzed data, and we got chance to publish that data. It was accepted by American Journal of Cardiology, and we also got chance for online web discussion for their American Cardiology Congress, which happened in August to September 2021. Do we need NOACs in all COVID patients or only high-risk group? If so, what is this high-risk group? Is it required for all variants of COVID or only Delta, or can we use it for Omicron as well? Do we extrapolate our data on Delta to Omicron as well? How long do we give those NOACs? What is the population which would need NOACs for a longer time? I'm sure a lot of us believe that few patients would require it for 6 months or more. Are few of the questions that are bubbling in my mind, and I'm sure they're bubbling in your mind as well. And to answer that, we have a fantastic panel today. I'm extremely thankful to ICS, Indian Chest Society, for giving me this opportunity to be here. And my special thanks to the President, Padma Shri, Dr. Behra, who has kept his special blessings and love for me for more than 2 decades. I know him for, 2 decades. I got to know him through his teachings, through his readings, through his lectures, through his meetings, and then got chance to work under his leadership on a couple of platforms. He was very close to my teacher, Professor Dr. Mohanty, and would always make it to all conferences that Mohanty sir organized. Pick up any national task force, pick up any national health advisory, and I'm certain Dr. Behra is the guiding force behind. My special thanks also to my another close friend, Dr. Rajesh Swankar, the most enthusiastic and most dedicated secretary that ICS has produced. My association again with him for more than a decade, and a perfect combination of, I would say, sincerity, simplicity, and dedication. Everybody here is aware that his effort has taken ICS to new heights. On this panel, we have two excellent speakers. The first one, Dr. G.C. Khilnani, name that is known to almost all of us. For last, if I'm not wrong, for last 20 months, sir has done excellent, exemplary work in educating doctors and people alike. Not a single day when I don't listen to Dr. Khilnani's comments, his views, his ideas, his advice on managing COVID. Be it to doctors, be it to media, be it to common man, he has played pivotal role in spreading the awareness about disease. He's currently the chairman of Institute of Pulmonary Critical Care and Sleep Medicine at PSRI Hospital Research Institute, Delhi. He was formerly the professor and head of department at AIIMS, Department of Pulmonology, Critical Care and Sleep Medicine. He has trained generations of chest physicians, and I'm sure everyone here has some amount of Dr. G.C. Khilnani in us. He published more than 250 research papers, and his research interest in air pollution, non-invasive ventilation, and ICU infections is well read. Appointed as a member of Technical Advisory Group on Global Air Pollution and Health by WHO for a period of 2 years. He was instrumental in formulating various guidelines, including asthma, COPD, pneumonia, non-invasive ventilators, to name a few. Contributed immensely during this COVID pandemic. And as early as probably, if I'm not mistaken, February 2020, just the COVID started, and he was appointed as a member of 3-member committee, which took part in planning the preparedness for Delhi. He was part of the Covaxin landmark trial, fell of several national bodies. He's shouldered responsibility of each and every important national bodies, and he's global governor for American College of Chest Physicians. He served as, he served in all national professional bodies and received various awards, to name a few. I think the last award that I'm aware of was the Lifetime Achievement Award by the Association of Physicians of India. With those words, I present Dr. Khilnani. We have Dr. Rajesh. Rajesh, my another close friend, currently working as the consultant and head of pulmonary medicine at Kochi, a tertiary care multi-specialty hospital. The institute offers postgraduate programs in respiratory medicine. He has his undergraduate training from Kerala, and then he completed his MD from Goa, did his DNB in respiratory disease in 2005. And he was a national level gold medalist. Rajesh, I'm especially jealous for this. I gave my DNB exam twice and I flunked both times, and then I gave up giving my DNB exam. And when I see you getting gold medal, I'm so jealous. He pursued his critical care in Apollo Hospital, Chennai, and was awarded Diploma in Critical Care by Indian Society Critical Care in 2008, recipient of Santosham Memorial Gold Medal at a national level for DNB Pulmonary in 2006, and a Young Pulmonology Award by Academy of Pulmonology and Critical Care in 2013. Reputed faculty on various national and international conferences, and I've seen him organize the NAPCON, which was the landmark conference that he organized, and NAPCON 19, the way he visualized the conference, the way he executed this conference, I think special mention for that. Core areas of interest as intensive respiratory care, allergy, immunology, and vaccination in respiratory diseases. Currently, he's playing very active role in managing COVID patients at Kochi. I also have to thank Mankind for associating with us, for doing this program and giving me this opportunity to reach out to you. I have my very close friend, Mr. Shrikant Ghosh, now currently working as a senior VP with Mankind. And I have friends like Manoj, Neeraj, and many other shouldering responsibility of this new division called Aspiris, which is going to cater to the respiratory field. I'm so happy that this is their first ever program in this field with this new division. The Mankind Aspiris doing the first program, first web CME with us at ICS. And I'm happy that I'm getting chance to host this event, which is going to be a historical event, which is going to be in the history of mankind, Asperis division for sure. And you all are going to be part of this mega history, which is in making. I wish all the best. I wish, pray, and hope that you continue doing programs, such educative programs for our delegates. On behalf of Indian Chess Society, the super faculty that I have, and all those 1,000+ delegates, we wish you, Asperis Division Mankind, Mili, Shrikant, Manoj, Neeraj, all the best. And the credit of doing this successful program goes to those 100+ Mankind team who have made this possible for us to unite on this platform. So friends, let's get set. Tighten your seat belts. We are ready to take off. Please make the best of today's program. Use the chat box that you have in front of you to put your questions, and I promise to get all of them answered by these faculties. With those words, I welcome the first speaker, Khilnali sir, and he's going to be talking about coagulopathy and SARS-CoV-2. Over to you, Khilnali sir.
Thank you, Dr. Agamora. Your prophetic words about this pandemic. You made us feel we are reliving, the beginning of this pandemic, the catastrophe that we saw, and there's nobody in this, I think, in the world who hasn't lost his near or dear, or a dear friend, or a neighbor. Everybody. And some are still crippling with breathlessness and oxygen, those who survived severe disease. And you really made reference to the learning that we had. We had no idea. We always thought steroids were detrimental for ARDS, which came out to be the most uncontroversial thing. Remdesivir came and went and came again. Hydroxychloroquine, ivermectin, favipiravir, things like that saw their own death over a period of time. So we were learning, and we are still learning as the variants are coming. And what I'm going to discuss is anticoagulants in COVID, why and how. Unfortunately, in medical science, everything is a double-edged sword. There's nothing which is safe. Even when we examine the patient, we might give them infection. We take the patient for CT scan, he may come with a catch infection and come back. So therefore, anticoagulants in COVID, the question I'm going to answer is why and how. And I'll take some time in explaining. The question is why anticoagulants for COVID, when actually for ARDS, more often than not, there's a big no-no. The COVID-19 has been associated with elevated rates of thromboembolic events. We know that. The pathophysiology of underlying the formation of these thrombi is not fully elucidated. And venous thromboembolism involving both in macrovascular and microvascular disease, and this in situ fatal thromboembolism have been observed in patients. And for some reason, the thromboembolic events are seen much more often in COVID than before. So we use thrombosis in COVID in 3 scenarios. One is moderate and severe COVID infection. That is one. Second is when there is suspicion or the diagnosis of venous thromboembolism. As compared to other ARDS, it is seen much more common. And third question, which I'll not be answering, maybe Dr. Rajesh would answer, for mild disease, as to is the role of any kind of anticoagulation that we'll be talking about. So I start with the case, a 34-year-old male, no previous comorbidities, history of contact with COVID. He had fever, throat pain, cough, and shortness of breath. On presentation to the emergency room, he had a tachycardia, tachypnea. His SpO2 was 84%. This was during the second wave. These days we are seeing it so much. The one room air blood pressure was normal. his COVID rapid antigen test was possible, and he had bilateral pneumonia. So, is this patient is a candidate for anticoagulation, or this patient is at the risk of venous thromboembolic event? These are two different things. This should not be mixed. Although the treatment is same, both requires anticoagulation, but it would be different. And I bring to you a landmark paper published in New England Journal of Medicine 2021, which looked at the histopathological comparison of COVID and influenza lung. These were the autopsy studies. And the third arm was healthy lungs, which were retrieved for donation but could not be put, but I'll not be talking about it. The summary was that there was pulmonary vascular endothelitis, thrombosis, and angiogenesis in COVID-19 infection. 7 lungs were obtained during autopsy from patients who died, and histological pattern was diffuse alveolar damage with perivascular T cell infiltration. There is a severe endothelial injury, widespread thrombosis with microangiopathy, and alveolar capillary microthrombi were 9 times as prevalent in patients with COVID-19 as in patients with influenza. And this is the histological picture. These arrows point towards the microthrombi, which were seen in the unfortunate people who died with COVID. Now, these are the salient features of this autopsy study. Clinically, many of these patients had elevated D-dimer level, as well as there was cutaneous changes in their extremities suggesting of thrombotic microangiopathy. And there was diffuse intravascular coagulation and large vessel thrombosis being linked to the multi-system organ failure, which led to the vasculopathy in the gas exchange network, could potentially contribute to hypoxemia and also the effect of proning that we see. And as I said, the alveolar capillary microthrombi were 9 times as prevalent as compared to the influenza ARDS lung, and this was obviously highly statistically significant. So summarizing it, that there was severe endothelial injury and disrupted endothelial membrane, vascular thrombosis with microangiopathy, and occlusion of alveolar capillaries. So this is the landmark study published in 2021, which exemplified that there is a thrombosis, there is vascular damage, and there is a potential role of anticoagulation. And as we say, D-dimer is in COVID is not a parameter of thrombosis only, it is a parameter of inflammation. The second question, which is important in answering the anticoagulation, is venous thromboembolism in COVID. And this was a study, the incidence of venous thromboembolism in mortality in patients with initial presentation with COVID-19. And it was seen, there were 1,871 symptomatic VT was seen in 118 patients, 101 pulmonary embolism, and 107 deep venous thrombosis, and 0.6% died. And these are the levels of the D-dimer levels. The question is pulmonary thromboembolism or venous thromboembolism is more common? This paper answered that question. The thromboembolism risk of COVID-19 is high and associated with higher risk of mortality. This was a meta-analysis which clearly showed 42 studies with 8,000 patients. Overall thromboembolism 21%, venous thromboembolism in ICU 31%, pulmonary embolism rate 13%, and in ICU it was 19%. The pool odds mortality was 74% higher if this complication was there. Now going ahead, COVID is a pre-coagulant state. The thromboembolic rate in COVID-19 are higher and associated with higher risk of death. There is a conclusive evidence, the autopsy finding and meta-analysis which I have showed. Disease is associated with coagulation dysfunction, which predisposes patient to increased risk of thromboembolism. This underscores the need for clinicians to implement thromboprophylaxis protocols in order to reduce the thromboembolic risk. Now, the question which is to be answered during this presentation is, who are the right candidates for anticoagulation? How to choose between various anticoagulation strategies? Prophylactic versus therapeutic anticoagulation dosages. How long should anticoagulation be given to the patient? And is there a recommendation for anticoagulation in OPD patients, which I will be only touching upon? So the answer is the first two questions. Who are the right candidates for anticoagulation and prophylactic versus therapeutic anticoagulation? So this was a study which addressed the treatment dose anticoagulation with in-hospital survival among hospitalized patients with COVID. This was the observation retrospective study of 2,773 hospitalized patients. 86 received systemic treatment dose anticoagulation. In hospital, mortality was similar. In patients who required mechanical ventilation, in hospital mortality was 29 versus 21%. So this was the difference between the overall patient, and you can see the wider difference in patients who required mechanical ventilation, where they received anticoagulation or didn't. Now, these are the initial, one can always criticize, what stupid people they were. The second question is effect of intermediate dose versus standard dose prophylactic anticoagulation on thrombotic event and extracorporeal membrane oxygenation treatment or mortality among the patient with COVID admitted to intensive care unit, a randomized clinical trial. This was done in Iran as a multicentric trial. Intermediate dose was compared with the standard prophylactic dose. What was important was that there was no difference when you gave intermediate or standard dose. Primary outcome was venous or arterial thrombosis, treatment with ECMO or mortality. Safety outcomes were major bleeding. So there was no difference in primary outcome. However, there was increased risk of cytopenia with intermediate dose. So this concluded that when you use anticoagulation, the prophylactic dose is good enough. And subsequently, there was a meta-analysis of 42 studies with 28,000 or more patients. There was no difference in hospital mortality whether you used prophylactic dose or therapeutic doses. However, the risk of bleeding understandably was more with the intermediate to therapeutic doses, and the grade of evidence was very low to moderate. So it was concluded that by this meta-analysis that prophylactic dosages are good enough. With that, the American Society of Hematology came out with the guidelines that prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for patients with coronavirus disease with critical illness who do not have suspected or confirmed venous thromboembolism. So therefore, if the patient has severe disease, this was recommendation 1 by American Society of Hematology. Another recommendation 2 was prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for patients with COVID-19 related acute illness who do not have suspected or confirmed VT. So therefore, conclusion was that all patients who are having severe disease should receive prophylactic dosages of anticoagulation. Which drug to use, I'll come to it later. What dose of anticoagulation should be empirically used in hospitalized COVID-19 patient ward or ICU in the absence of confirmed VT? So all hospitalized patients with acute illness with COVID-19 should receive at minimum pharmacological thromboprophylaxis. In patients for whom anticoagulants are contraindicated or unavailable, mechanical thromboembolus should be used. Now, a question that poses which one to use. Now, if you want to know which are the anticoagulants, it could be parenteral or it could be oral, it could be indirect, it could be direct. Unfractionated heparin, which is time-honored, low molecular weight heparin, fondaparinux, or you can use, these drugs are not available to us, so I am not describing. What is recent is factor 10A inhibitors, rivaroxaban, apixaban, endoxaban, which we are using, and thrombin inhibitor, dabigatran. The question is which one to use. No low molecular heparin. Most of available studies use low molecular weight heparin. The good quality data available, also the meta-analysis. Most of the working group advise using parenteral anticoagulation in hospitalized patients, and there is a good safety profile, does not require monitoring. Newer oral anticoagulants, which are actually recommended for acute thromboembolism, and they say it is said that it is as good as the low molecular heparin, but there is lack of RCTs in the hospital setting as far as COVID-19 is concerned. There are drug-drug interaction. Other problem is that we don't have antidotes for them, whereas the effect of heparin, low molecular heparin, is short-lived and can be easily reversed. And because of this, it adds to the complexity. You have to put central line, you have to do some procedure, you have to put ICTs for pneumothoraces and all those things. Reversing the effect of newer oral anticoagulants could be a problem. So therefore, the low molecular weight heparin and unfractionated heparin, whenever the creatinine clearance is less than 30%, is the drug of choice. Another question which needs to be answered is how long should anticoagulant be given in COVID patients? And that is very important. And this was a study. Now, what I'm talking about after the discharge. While in the hospital, there is no question. Patient has to be anticoagulation, but after the hospital discharge, should anticoagulation be done, whether by injection or by newer oral coagulant? So this was a study which was published in Lancet. This is January 2022. Rivaroxaban versus no anticoagulation for post-discharge thromboprophylaxis after hospitalization for COVID, what is called as Michel study, an open-label, multicentric randomized controlled trial. This is an elegant study which actually has, which will change our practice. Till then we were confused as to at the end of discharge, should we give newer oral anticoagulant for, sometimes we gave it for 10 days, sometimes we gave it for 15 days, sometimes we titrated with D-dimer, which was also not evidence-based. So this is a study. As I said, rivaroxaban with no anticoagulation. It was open-label, multi-center randomized trial. Patient hospitalized with COVID-19 had increased risk of VTE. With a score of more than 4 or 2 to 3 with D-dimer of more than 500 were included, and 320 patients received rivaroxaban versus placebo. The primary efficacy outcome in the intention to treat analysis was composite of symptomatic or fatal venous thromboembolism, asymptomatic venous thromboembolism, symptomatic arterial thromboembolism, or cardiovascular death at day 35. And you can see the blue versus pink color. There is a distinct benefit of rivaroxaban over control. In patients at high risk of discharge after hospitalization due to COVID-19, thromboprophylaxis with rivaroxaban 10 mg per day for 35 improved clinical outcome compared to no extended thromboprophylaxis. So how long to give thromboprophylaxis? 35 days after the discharge from the hospital in moderate to severe case. What about anticoagulation for mild or OPD patients? Now this was a study where it was compared aspirin versus therapeutic apixaban with prophylactic apixaban versus placebo. This was called active 4B randomized clinical trial. I'll just show you the results. No benefit of anticoagulation patients with mild disease. So therefore, this answers the question. When should you use anticoagulation? Patient who has mild disease, and we know that the current therapy includes cocktail antibody 3, as it is popularly called, or you use antiviral drugs like molnupiravir or paxlovid, or you use remdesivir in mild disease in order to prevent the disease becoming severe. But there's no benefit of anticoagulation in patients with mild disease. That is what has been discerned. So, summarizing my presentation, all patients with acute COVID illness hospitalized should receive prophylactic anticoagulation till discharge. Low molecular weight heparin is the drug of choice, or unfractionated heparin if the low molecular weight heparin cannot be given. High-risk patients should receive extended thromboprophylaxis after discharge with newer oral anticoagulants unless contraindicated. There is no role of any kind of anticoagulation in mild disease. So, ladies and gentlemen, thank you very much for your kind attention, and I'll be willing to answer any questions.
Thank you very much, sir. That was a fantastic presentation. Actually, as expected, we were expecting this lovely presentation from you. Thank you for doing that justice. And now we move on to the next talk, which is by my friend, Dr. V. Rajesh. And he's going to be talking about prophylaxis and management of thromboembolic events in COVID-19. Over to you, Dr. Rajesh.
Very good evening to all the esteemed delegates and faculty. At the outset, I would like to express my sincere gratitude to the ICS team as well as Aspiris Mankind team for coming up with this very innovative and very clinically relevant CME. And I would place upon record my sincere gratitude for allowing me to be a part of a program where people like Hilani sir and Agam sir are there. In fact, Agam sir, you asked me how I passed my DNB. In fact, there is a secret to that. The examiner was none other than Hilani sir, one of the examiners. So I think that answers the question. Are my slides visible, sir?
Yes, they're visible.
And I hope
yes.
It's moving.
It's moving.
So around 12 minutes, I will try to share with you the pathophysiology of D-dimer in a normal person as well as in a patient with COVID-19, and how can D-dimer levels be used for guiding diagnosis, prophylaxis, and treatment of venous thromboembolism in COVID-19. The next 12 minutes, I will just try to share with you the outpatient thromboprophylaxis in COVID-19, which actually has been discussed by Hilani sir, but probably that part we will just have a second discussion just to reiterate facts. So we'll start off with a couple of disclaimers that there are inherent uncertainties in knowledge and evidences of a relatively new disease that has been with us for the last couple of years only. And there is significant overlap between Hilani sir's talk and my talk, but I see it as an opportunity for reinforcing some of the key aspects in thromboprophylaxis in COVID-19. So the first question has been very, very clearly answered. Are COVID-19 patients at higher risk of thromboembolic events? Yes. All the three components of the visual are the stasis, vessel wall injury, hypercoagulability, all those things operate in COVID-19. Stasis due to the COVID-19 disease per se, immobility, venous stasis, etc. A lot of coagulation parameters are elevated, including the factor 5, 7, von Willebrand's factor, etc. And direct viral infection can cause endothelial dysfunction and create vessel wall injury. So it can take the shape of a typical thromboembolic event like DVT or a secondary pulmonary embolism or an in situ pulmonary thromboembolism. Or it can be an in situ immunothrombosis in smaller pulmonary arteries and capillaries, which is difficult to image. Probably we see it as a postmortem diagnosis. This is a distinct COVID-19 induced pulmonary intravascular coagulopathy. And in addition to that, we see the arterial events also in the form of cerebrovascular accidents and even peripheral vascular occlusive disease. And this is actually been shared. So a pooled analysis of almost 18,000 patients said that there is almost a 17% crude incidence rate of thromboembolic phenomena when it comes to hospitalized COVID patients, almost 12% for DVT and 7% for thromboembolism. And there is higher incidence in the ICU patients versus ward patients. The risk factors include severe disease or ICU care, a longer duration of hospital care or follow-up, advancing age, and a baseline altered coagulation parameters when the patient is getting admitted. And the distressing fact is that this occurs despite thromboprophylaxis, at least in a small proportion of patients. But the positive side is that all this venous thromboembolic phenomena may not be symptomatic. So if we keep on imaging, we find something, but it may not have a clinical relevance. So what are the hematological lab test abnormalities in COVID-19, and would they be helpful in diagnosing thromboembolic phenomena in COVID-19 patients? Now, lab coagulation abnormalities are pretty common in hospitalized patients with severe COVID-19. And that includes a mild degree of thrombocytopenia as occurs in most of the viral diseases, a mild increase in prothrombin time, a high level of fibrinogen, and elevated D dimers. But it needs to be remembered that a marked reduction in platelets less than 50,000 or something, or a marked reduced fibrinogen, or elevation of APTT out of proportion to PT, all these things are atypical findings. And if they are present in a patient with COVID, probably we need to search for a second cause for this type of alteration of coagulation parameters. And the diagnosis of thromboembolic phenomena in COVID-19 pretty much the same basics, because since there is a high incidence, we should have a low threshold for suspecting and carrying out the diagnostic test. So pulmonary thromboembolism should be suspected if there is a sudden worsening of hypoxemia, significant drop in blood pressure, new onset tachycardia, oxygen requirements disproportionate to the severity of pneumonia, etc., etc. And of course, the clinical signs of deep venous thrombosis. The special challenges that we face for diagnosing thromboembolic phenomena in a COVID scenario is that sometimes the patient may be sick enough. So the clinical state may make it difficult for the patient to be mobilized to the radiology department for a definitive study. Of course, we can have a bedside lower limb venous Doppler. CPAP dependent patient or an intubated patient requiring prone ventilation is practically not possible to shift into a CTPA. And again, you need to consider local radiology protocols, considering the risk of transmission. And there is always a risk of saturation of radiological services due to very high numbers, which can suddenly sprout out when it comes to COVID-19. And there's a demand for a large number of staff for transportation. That also can be challenging, especially when a lot of staff get sick. So there may be a few situations where, very high pre-test probability of thromboembolism. Maybe you can do a therapeutic anticoagulation, but that's not a standard procedure. In a very special challenge, a very special scenario, probably you can go ahead after informed consent with the patient. So COVID-19 D dimer levels and thrombosis risks, again, here it needs to be clarified. A couple of things need to be clarified. D dimer, if we see, it's basically the degradation product of cross-linked fibrin that is cross-linked by factor 13. So it basically reflects ongoing activation of the hemostatic system. But at the same time, it needs to be remembered that D dimer is an acute phase substance which can be elevated in conditions like pregnancy, any inflammatory state, some of the malignancies, trauma, post-surgical events, liver disease, etc. Again, lipemia, high triglyceride level, elevated bilirubin level, etc., may falsely increase the D dimer level also. So all these factors need to be considered before we interpret a high D dimer levels in a patient with COVID. So a high D dimer levels, if it is present in COVID, may indicate a thromboembolic phenomena and fibrin breakdown, which again may be helpful in making a clinical suspicion of a thromboembolic event. Or it may simply be a marker of severe lung inflammation and increased fibrin turnover. So retrospective studies have looked at the value of D dimer levels in predicting the risk of venous thromboembolism. And as I said, it's a non-specific acute phase reactant. So it may be elevated in acute inflammatory states like pneumonias and other causes of sepsis, as well as in thromboembolic events. So it has a very good prognostic value in hospitalized patients. It actually is a marker of more severe disease, and higher D dimer levels were seen in non-survivors with COVID as compared with survivors. And elevated D dimers were seen in almost 46% of patients in a series of around 1,100 patients. But the problem here is that there is a significant overlap. So there's a substantial overlap of values of D dimer between cases with and without pulmonary thromboembolism. So the specific cutoff will be very challenging. If you, as an example, if we can see this particular study, This was the Spanish study which looked at around 242 COVID-19 patients with suspected thromboembolism who underwent CTPA. And of that, around 73 patients had a thromboembolism. So what they looked at is, of the 243 patients, 96 of them had elevated D-dimer levels. So just because of the elevated D-dimer levels, they can distinguish between someone who had embolism and someone who didn't have embolism. But the 73 patients who had a thromboembolism on CTPA, their mean D-dimer level was much higher than the patients who did not have a CTPA, did not have a thromboembolism on CTPA. But again, the challenge is that the levels are overlapping and the optimal cutoff is not very conclusive. And this particular study suggested an optimal cutoff around 2,900 nanograms per ml. But again, the sensitivity and specificity were pretty mediocre. Now, that brings us to the events of post-discharge thromboembolic event in a patient with COVID-19. This particular registry actually looked at around 4,600 patients hospitalized with COVID-19, and they were followed up for up to 90 days after discharge. The venous thromboembolism events, arterial thromboembolism, all-cause mortality, etc., occurred in 1.5%, 1.7%, and 4.8% of patients. And on multivariate analysis, it was seen that the risk factors for venous thromboembolic and arterial thromboembolic events included advanced age, previous history of venous thromboembolism, ICU stay and a long hospital stay, presence of chronic kidney disease, previous peripheral vascular occlusive disease, CAD, or a high VTA prediction score at discharge. And it was seen that if you take it alone, so you take D-dimer alone in the absence of other risk factors, even a 6 times elevated D-dimer level was not an independent risk factor for venous thromboembolic events if none of the previous risk factors were present. So the clinical implication will be that in the absence of other risk factors, just treating the D-dimer levels at discharge may not be that good, as I will come to in my subsequent slides. Again, the impact of persistent D-dimer elevation. This study actually looked at patients recovering from COVID and having a pre-existing lung disease. The D-dimer levels, inflammatory markers, imaging, blood gases, etc., were measured after a mean time of around 2 to 3 months after recovery. And it was seen that only 6% of patients with an elevated D-dimer had evidence of venous thromboembolism on follow-up imaging. So it was concluded that an elevated D-dimer after discharge may be a marker of severe COVID disease rather than a risk prediction tool for venous thromboembolism event if it is taken alone. Of course, if it is combined with other aspects, other factors, then it might have a predictive value. And anticoagulation decisions need not be based on elevated D-dimers alone. So if I can just conclude what D-dimer is in COVID, it's a marker of severe disease and poor outcomes. Elevated levels can be seen even in the absence of venous thromboembolic events. Optimal cutoffs have been suggested, but has poor clinical performance parameters. But a normal value of D-dimer in a patient suspected, it virtually rules out venous thromboembolic state if it is measured by a correct assay. So in one sentence, D-dimer in COVID-19 is a guide with a lot of pitfalls. So just move to the second aspect, another 5 minutes on the domiciliary anticoagulation in COVID-19 patients, which actually Khilnani sir has already touched upon and explained, but I will just have a recapitulation of that fact. Inpatient thromboprophylaxis, Khilnani sir has explained in detail. Now, outpatient thromboprophylaxis happens in 2 sets, maybe considering 2 sets of patients. One is COVID-19 patients who are not or have never become sick enough to get hospitalized. The second is COVID-19 patients who are discharged after a period of hospitalization because they were reasonably sick. So the recommendations in each of this category is different. You see the incidence of thromboembolic phenomenon after discharge. I have shared a previous slide. Around 1,800 plus COVID-19 patients discharged without anticoagulation was followed up, and it was seen that thromboembolism was occurred only in 9 patients. That is almost 4.8 per 1,000 cases, which is almost similar to the occurrence in general discharge population in the pre-COVID era. Again, this study I have already previously mentioned 4,000 the risk of venous thromboembolism, arterial thromboembolism, and the mortality was 1.5, 1.7, and 4.8%. And the risk factors also I have mentioned. So, what are the evidences on outpatient thromboprophylaxis in non-hospitalized patients? I think Khilnani sir has already shared the results of the active 4B randomized controlled trials. This actually was done in outpatients with COVID-19 who were never sick enough to get admitted. And they had no additional risk factors for bleeding or no pre-existing risk factors for antiplatelet or anticoagulant therapy. So they were divided into 4 arms: the placebo, aspirin, prophylactic apixaban, and therapeutic apixaban. And the primary outcome was a composite event. And this particular study was prematurely terminated because of low occurrence of events in both arms, and there is a higher risk of complications in the treatment arm. So therapy with antiplatelets or varying doses of oral anticoagulants did not improve outcomes, clinically significant outcomes in outpatients who were never hospitalized. So in this particular group of patients, there is no role for a outpatient anticoagulation. Whereas the scenario is slightly different in someone who is hospitalized with COVID and he is getting ready for discharge. So any patient who is hospitalized, as Kilani sir said, he should receive a thromboprophylaxis. If there are contraindications for a pharmacothromboprophylaxis, then at least mechanical thromboprophylaxis. And in most cases, a therapeutic or a prophylactic dose will be adequate, except in very, very selected cases when there may be a role for therapeutic anticoagulation. So again, this particular study was discussed, the Michel study. This actually was a Brazilian open-label multi-center RCT on 320 patients with COVID-19. And in contrast to this study, this was done in patients having very clear-cut high-risk factors for venous thromboembolic events. The risk factors, if we can make it objective, these patients had an improved VT score of 4 or more, or a score of 2 to 3 with a dimer level of more than 500 nanograms per ml. So they were randomized in a 1:1 fashion for no anticoagulation versus rivaroxaban for 35 days after discharge. The efficacy measures were symptomatic or fatal thromboembolism, asymptomatic venous embolism, symptomatic arterial, or any cause of cardiovascular cause of death by 35 days of discharge. And safety measure was major bleeding. It was seen that the lesser occurrence of venous thromboembolic events and arterial thromboembolic events was group which actually received rivaroxaban with no additional risk of bleeding. So based on this Michel study, probably what we can recommend is someone who has been hospitalized with COVID has received in-hospital low molecular weight heparin. When he is getting discharged, if he has a high risk for, if it's a high risk candidate for a venous thromboembolic event, as measured by this particular score, that is the improved VT score, and he has no contraindications as we come to a bleeding risk score also is there. So there are indications that make him a high risk candidate for thromboprophylaxis, and there are no contraindications for a pharmacological thromboprophylaxis. Go ahead and give an oral anticoagulant, newer oral anticoagulant in such patients. So based on these recommendations on post-discharge thromboprophylaxis, again the ASH mentions that against using outpatient anticoagulant on a routine basis, but it may be a reasonable strategy in a small group of patients who are judged to be at high risk of thrombotic risk and low bleeding risk. And this risk, what are these risks? A patient who has a high risk of VT, including an improved VT score of more than 4, or age greater than 60, elevated D-dimer levels more than twice the upper limit of normal, etc., etc. If the creatinine clearance is more than 15, we can use rivaroxaban. The creatinine clearance is less than 15, we can dose a low dose aspirin for around 30 days after discharge. And again, the patient should have a low risk of bleeding as evidenced by the improved bleed score, or simply if we cannot calculate the improved bleed score, the patient should not have any high risk factors for bleeding like bronchiectasis, pulmonary cavities, dual antiplatelet therapy, active cancer with high bleeding risk such as GI cancer or intracranial cancer, recent bleed, GI ulcer, etc., etc. In the absence of this, we can probably consider a 30-day oral anticoagulation in patients who are discharged after the acute hospitalization. And this is the risk assessment score, VT risk assessment score, and this is the VT bleed risk score. So finally, before I wind up, there has been some data which says that the incidence of thromboembolic events in COVID-19 may not be as high as what we perceive. The systematic review and meta-analysis of studies reporting the incidence of thromboembolism in COVID-19 patients, a total of 57 studies was studied, both ICU and non-ICU populations were studied. And it was seen that thromboembolism incidence of 7.1% was seen in hospitalized COVID patients, and an incidence of 13.7 in ICU COVID patients. The incidence of microthrombi was not clear, but it was seen that studies with a larger sample size reveal lesser incidence of thromboembolism because it's a smaller study. Probably they recruit patients who are at high risk or who have suspected clinical factors. So it tends to be skewed in the line of a thromboembolism rather than a non-selective group of COVID patients. So in studies with sample size of more than 400, the incidence of pulmonary thromboembolism was only 3%. And the largest study with a sample size of 2,200 revealed an occurrence of only 2.3%. So the understanding is constantly evolving. Initially, we thought that COVID-19 patients, especially those with severe COVID, have high thrombotic risk and may benefit from high-dose therapeutic anticoagulation. But later we realized that standard thromboprophylaxis is more than adequate. Then we realized that COVID patients have bleeding risk also, so please be judicious with anticoagulation. Then administer outpatient anticoagulation only to very, very selected group. And after all, the thrombotic risk in hospitalized patients is pretty high, but not as high as what we perceived maybe a year back. That is the 360-degree turn of events that has happened with regard to thromboembolic events in COVID. So interpret and use D-dimer values in conjunction with clinical parameters. So one slide, if I can just summarize. Second opinion to that, although the magnitude is less than what previously we had perceived. Venous thromboembolic events occurs in 2 to 17% of hospitalized patients and is higher in sick ICU patients. The similar principles of diagnosis operates. Might need empirical anticoagulation if the patient is not, it's not possible to shift the patient for an imaging. Almost all hospitalized COVID patients merit anticoagulation in the absence of contraindications, and standard prophylactic low molecular heparin dose is the most appropriate one. Therapeutic dose in hospitalized non-critically ill patients, the superiority was established in one trial, but again, very limited group of patients. And OPD anticoagulation in those who are never admitted, that's not required. If someone is getting discharged after admission, if they have higher risk factors, then probably anticoagulate them for newer anticoagulants for a period of 1 month. Thank you. And again, thank Khilnani sir for being my
it was a splendid
teacher
presentation.
and mentor.
Where is our moderator?
Just hold for 2 seconds. I'll just connect with Agam sir.
Agam sir is not there in the.
There's some challenge with Agam sir's internet, so that's why he's just coming.
Just 1 second. Yeah, sir is back.
Sir,
Sir, you are.
Sir is there.
Oh, I'm so sorry. I'm so sorry. There was some internet issue. I must thank Dr. Rajesh for a fantastic talk. I was there till the last, your take-home message, and then I was just trying to put on my camera, and then internet went. Allow me to, share with you that we've got 700 plus delegates today. Today, there are back-to-back programs going on. There are so many programs going on, but still 700 people chose to be here, and the real credit goes to Khilnani sir and Rajesh for giving this excellent talk, and people who are waiting to hear to this crystal clear message that both of you have. And I've got many questions, but I've shortlisted a few questions which I'm going to be asking you, and we would have a rapid fire answers because most of the points are very well described. A lot of people would have framed their questions before listening to your talk, and a lot of these questions are already sorted. But I have a question by Dr. Ponatha Vindhya from Bangalore. Areva, we have a delegate from Bangalore. We have a delegate from Buldanshar. And the doctor wants to know anticoagulation in mild cases with normal D-dimer. You did touch upon this issue. I would start with Dr. Rajesh. What is your comment on anticoagulation in mild cases with normal D-dimer levels? I think we need to add two things here, whether patient has got any high risk or no high risk. So I think I would ask Rajesh to answer that question for two category of patients.
Yes, sir. I think Khilnani sir also has explained, and I also told that if the patient is not hospitalized at all, and he doesn't have a second indication for high risk indication, which makes him at high risk of thromboembolic events, then anticoagulation or thromboprophylaxis has no role in mild cases, whatever be the D-dimer.
Correct. And Khilnani sir, I want to ask you the second part of the same query the doctor has, and he's talking about the role of aspirin.
No role of aspirin. One line answer.
So sir has given a simple answer that it is not a thrombotic, it is not a platelet disorder, and hence please do not use aspirin. Use of retifuse. Retaplase asked by in the severe COVID-19 or pulmonary embolism? I think Dr. Khilnani, what he's trying to ask us about,
Thrombolytic
if there is
therapy.
pulmonary embolism, would you
Thrombolytic
lice
therapy.
it?
No,
Yes.
he is asking about thrombolytic therapy, which is actually
Yes.
justified. We didn't touch upon that because we were focusing on COVID and anticoagulation. So
yes.
that question is very good actually and very relevant. So the thrombolysis in pulmonary it has no role as a prophylactic, of course. The thrombolysis is done in patients who have got life-threatening pulmonary embolism, who have got intractable hypotension. That means the embolism is either a very large embolus or it is multiple emboli leading to hypotension, and it is a life-saving procedure, but with risk of bleeding. So it is indicated only in people who have severe hypotension, which is intractable, where this ATYPICAL or whatever you call it, thrombolytic therapy, / surgery is considered, out of it. Since the question is asked about thrombolytic therapy, it is indicated, but it is indicated in COVID as much as indicated in any severe pulmonary thromboembolism.
So, sir, has given a very clear message that pulmonary embolism must be treated as you would manage pulmonary embolism, even if this patient has got COVID-related pulmonary thromboembolism, and thrombolytics must be used if patient has got complications because of embolism. Trust me, till 50% of the cross-sectional area is not compromised with thrombus, you don't get hypotension, you don't get hypoxia. That is what sir was saying. If it is a severe pulmonary embolism, patient will have hypotension, patient will have hypoxia, and that needs to be treated with.
And the risk of bleeding has to be considered. Risk of bleeding has to
so that goes, you have to weigh that there may be a risk of bleeding when you use anticoagulation. Yes. There is a question by Dr. Anand Rajendra Gavsane from Pusad. Oh, Yavatmal. I have a lot of friends in Yavatmal, Dr. Rajendra. And Dr. Rajendra wants to know the duration and dose of oral antiplatelet after discharge. I think, sir, this message is very clearly given. You need no antiplatelets in COVID patients, but you would continue using antiplatelet provided they have any other indications for antiplatelet. Say patient is a case of ISD, stable ISD, and he's on antiplatelet, you will continue it as you would continue it for his comorbid disease, but there is no role of antiplatelet otherwise. Is there any role in mild but high risk cases? Dr. Khilnani, sir, he wants to know if antiplatelet has got any role in hypertension more than 60 years of age, mild COVID.
No. The message is very clear, and you have
Correct.
actually said it before. I said it. I don't have to reinforce that part. As far as COVID concerned, aspirin or clopidogrel has no role. If the indications are other than COVID, so be it. You don't have to stop
Correct.
them.
Absolutely. So if you're talking about primary prophylaxis for this patients, for say cardiac disorders, etc., you may consider it otherwise as you would do it. But because of COVID, please don't consider any antiplatelet therapy.
Question is very valid because so many people were prescribing it, so many prescriptions post-COVID. With the marginally raised D-dimer, they thought that it is a safe bet to give aspirin or clopidogrel.
Correct.
Which is
a lot of people have fear of using
evidence
NOACs. Correct. A lot of people have fear of using NOACs, thinking that it may lead to bleeding disorders. But trust me, if chosen in the right kind of patient, most of the NOACs are safe, provided you've chosen the right NOACs, provided you've taken the right indications and patient's comorbidities are taken into consideration. As sir said, probably creatinine clearance, etc., needs to be kept in mind before you choose the right NOAC. In that connection, Dr. Rajesh, we have a next question. And the question is by, again, Yavatmal Dr. Anand. And he wants to know, is there any advantage or how do you choose from different heparins? Conventional heparins, unfractionated heparins, even different unfractionated heparins. How would you choose? Any particular points you would keep in mind before choosing one?
Sir, by and large, sir,
or by and large, they all are the same.
So by and large, most of the molecular weight heparins would do. They have an edge over oral anticoagulants as well as unfractionated heparin, in the sense the incidence of heparin-induced thrombocytopenia is much less with the molecular weight heparin. Among that, probably the best volume of experience comes with enoxaparin. So that's probably why we keep on using it. But if someone has a very low creatinine clearance, then fraxiparin will be a better choice.
Correct. By and large, there is, of course, conventional heparins can be used, but with availability of unfractionated heparin, practice is changing. The ease of, giving these molecules probably has advantage there. There is no particular advantage of choosing one molecule of unfractionated heparin. You could use any depending on the cost and availability at your centers. Dr. Khilani, would you want to add anything to that?
No, it's perfect. I totally agree with that.
So you have to, because I'm using whatever you've taught me. You are our teachers, so this
No,
is a
but there's
reflection of
nothing.
whatever we've learned from you over the
Not
last
for
2
the
years.
sake of talking. You are so to the point, and you are being so humble. Otherwise, you are self-sufficient. I know.
Are sir, Dr. Imran Khan. Dr. Imran Khan from Pondicherry. He wants to know the current ICMR guidelines removed anticoagulation therapy in severe COVID-19 due to high risk of bleeding. What's your opinion, Dr. Hilani, sir?
No, I cannot opine on that. Why should I be talking about what ICMR has written? I can talk about science.
Correct.
I have already produced the evidence. I have already produced the autopsy reports. I always produce the evidence of benefit with anticoagulation therapy. I am actually not aware that ICMR has removed it. I don't know. But
yes,
every physician in this country, for moderate and severe COVID admitted patient, anticoagulation are standard of care.
Yes, and I completely agree. Trust me. Yes, there are evidences, but whatever we are talking is from our own experiences as well. Dr. Khilani has the highest experience among all of us, but Rajesh and myself also have managed fairly decent cases of COVID. And trust me, any patient who requires hospitalization would be the candidate for low molecular heparin if there are no contraindications. Rajesh very beautifully mentioned about the list of contraindications or the relative risk that you have to keep in mind. But you imagine patient is room bound. In first wave, we've admitted patients for what, 14, 15, 20 days. And now patients, such a small houses they have. And if patient has got any additional risk factor like obesity or like any other past history of deep vein thrombosis, etc., all these patients are definite candidate for anticoagulation. Now, how long anticoagulation needs to be continued? Again, you need to weigh the risk benefits for that particular case. But I would be most comfortable, as Rajesh showed in his study about 35 days that he said, even sir spoke about 35 days. I would be most comfortable giving it for 6 weeks. And in some small subset of patients who are bedridden for a variety of other illnesses, may require it for a longer duration. Dr. Anand from Baramati, we have Dr. from Baramati as well, and he wants to know that duration and dose of oral antiplatelets. Sir, no oral antiplatelets for COVID, that is for sure. And when you say that enox are in unfractionated heparin or other heparins in hospitalized patients, you would continue this treatment till they are in the hospital. So whatever is the indication for hospitalization, if patient continues to be in hospital, I think please continue low molecular heparin for their entire stay in the hospital. The next question is by Dr. Aviral Gupta from Delhi. Dr. Gupta from Delhi. And he wants to know role of other factor 10A inhibitors, apixaban, direct thrombin, that is dabigatran, in thromboprophylaxis of COVID-19. So Dr. Khilani, he wants to know about, we have various NOACs available. So how would you choose the right NOAC?
I don't use dabigatran, which was actually dabigatran, okay, which was used for atrial fibrillation to start with. If you go into the history of that, and we have now more experience with apixaban and rivaroxaban. And it's not that dabigatran is an inferior newer anticoagulant. The mechanism is different. It has several interactions. So if you are using apixaban, you are not doing anything wrong. Just because the recent trial, which got published this year only with rivaroxaban. For example, I would commit myself that I have been using apixaban in all my patients and not rivaroxaban. More often apixaban in smaller dosages, half the therapeutic dosages for the post-COVID patient. At that time, the evidence was not there about rivaroxaban. But rivaroxaban is a time-honored drug which has been used for even acute pulmonary thromboembolism, and it is equated the heparin. So whether you want to use apixaban, go ahead and use it. There is nothing wrong in that. Only thing what has come out with this study, Michel's study, is that 35 days. I must commit myself that we were using it for 2 to 3 weeks actually, in majority of cases. But now the further evidence has come, so we'll use it for longer time. Yeah. I don't know
Oh,
whether
perfect.
that answers
So
the
what sir
question.
says is absolutely right. There is no great advantage of choosing whichever Novax you can easily, get it, whichever is available in your area, and cost benefit it has, I think would be enough to choose it from, unless you have issues with creatinine clearance, unless there are specific situations where you may have to choose one over the other. As sir said, Apixaban was a little less used, but with availability of cheaper versions of this molecule, I think the uses picked up earlier, because of the cost constraint, people using other molecules. But I think we have the good experience of Epixa even with rivaroxaban. Dabigatran, a lot of people here in Mumbai have been using, and initially all those hematologists who were involved in the COVID management that I had, they have suggested dabigatran also for a significant group of patients. You have, as I said, there are different dosages available, and you have to choose dose based on creatinine clearance, age, and other comorbidities. Thank you. The next question by Dr. Mittal Kanpur. We have doctors from Kanpur as well. Is there any increase in MI incidence post-COVID? Yes, post-COVID, there is definite increase in a lot of inflammatory disorders, and cardiac disease being one inflammatory disorder. As I told you, my first ever patient who was admitted was actually a stroke patient. Rajesh, would you want to comment on your experience of cardiac comorbidities post-COVID? Are you seeing more?
Yes, sir, definitely, sir. I think, as you correctly said, most of the inflammatory, systemic inflammatory diseases, including myocardial and other thromboembolic phenomena, CVA, peripheral embolism, most of the things we are seeing, and even COPD exacerbations that way.
Correct. And we have doctor from Srinagar as well, Dr. Mukhtar
So
Mir.
if I could add to that, sorry.
Sir, please.
So not only as we know, it's a thrombotic state, and so there have been incidents of sudden death in the post-COVID, as we call it in the long, and whether they are because of the acute MI or arrhythmia. There are also rhythm disturbances which have been seen, and also there's evidence of cardiomyopathy post-COVID with low ejection fraction, which is partly reversible. All these things have been documented. Thank you.
Thank you, sir.
Perfect. We have a doctor from Srinagar. Dr. Mukhtar wants to know use of anticoagulant without coagulogram. In the sense, would you keep on doing blood tests when you put them on anticoagulation? Trust me, you don't really need great monitoring when you're putting patients on this NOACs. There is hardly any bleeding disorders, and you don't really need regular monitoring of your coagulation profiles. I think that's all. We have a few questions, but I think most of the questions are repeated. And I must thank those 740 delegates who have logged in today for your valuable time. I must thank Mankind and Indian Chess Society for giving us this platform. And it's my proud privilege to be there on the same platform where Dr. Khilnani sir is there, and of course, my dear friend Rajesh is there. Before I wind up this session, I would want to take up a take-home message. And Rajesh, I would ask you to give a take-home message first.
Sir, COVID is a procoagulant state. So in the absence of contraindications in hospitalized patients, all patients should be on anticoagulation, prophylactic anticoagulation.
Wow, they were very crisp. Khilnani sir?
So I have spoken enough about anticoagulation. I would say that the focus has been now, the focus is prevention by vaccination, which reduces the severity. Now the focus is at reducing the severity so that nobody reaches the hospital and reaches death by antiviral or novel and monoclonal antibodies. As far as treatment of acute illness with COVID concerned, we have almost reached the plateau, actually. Plateau in the sense that there are no significant advances. And there were a lot of controversies which have been put to rest. So I think everybody should think of treating COVID in such a way that all the mild disease are stopped there with the treatment, and people don't reach the hospital. Thank you.
Thank you very much, sir. And I would also probably echo the same sentiments. And I believe, and I'm sure everybody here would agree, that COVID is here to stay. We will have to make adjustments with it. We'll have to learn to live with it. The social distancing, masking, sanitization, and probably cough etiquette would go a long way in, probably keeping you safe, I would say. I came across a very nice WhatsApp message. Khilnani sir, somebody sent me a message saying that the studies are important, but your self-experience is the best. I recently came across a study which said that birthdays are very important. And there was a very nicely concluded study which said people who have more birthdays live longer. And every study will have to be taken with a pinch of salt. Though you have a lot of studies, as Rajesh said, probably there are studies which spoke about complete coagulation, then came, they probably took a complete, nice slide he showed, where he says there is a complete U-turn and says you manage, COVID hypercoagulability as otherwise you would manage it with any other illness. It has got no additional hypercoagulable state. And with this new variant, we are seeing less and less inflammation. We are seeing less and less cytokine storms. We are seeing less and less hyperimmune state. And so is the hypercoagulability less with this variant. Please use your wisdom. Please do participate in such meetings where jointly we would learn more and which would help our patients with their tough situations. Thank you very much for your patience. Thank you very much for your time. Thank you very much for the opportunity. Thanks, ICS. Thanks, Mankind.
Thank you, Khilnani sir.
Thank you.
Thank you, Rajesh. Thank you, Agam. You have always
Thank you, sir.
very generous with your comments, and I must appreciate the Mankind and the new division. But believe me that initial prophetic comments by Agam, not about me or Rajesh, what he said about the COVID pandemic was indeed prophetic, and only person like him can give that, who has a grassroots.
It's all your blessings.
Yes,
I'm your student, and I would
who
love
has
to
a
remain your student.
let me finish. Who has a grassroots experience and is humble at the same time. Thank you very much.
Thank you, sir.
Thank you, Agam sir.
Thank you, Agam sir. Thank you, Gurunat sir. Thank you. Bye.
Good night. Good night.